This presentation is a project proposal for implementing an alternative pain treatment program in a hospital emergency department setting, presented by myself, Brandy Ventrello. The objectives to this presentation are the history of the proposal, the why, who, and where, establish the need or purpose for the program, identify who the stakeholders are, how they are impacted, and how to communicate with them, determine what two goals this program will attempt to achieve, list the requirements or tools needed to attain the goals stated, review scholarly articles to address the need for this type of a program, incorporate a biblical worldview in relation to the need for this program, and in conclusion, I will reiterate why this program is needed and a quick overview of what I am trying to achieve. This subject was selected based on a community need. There has been quite an emphasis on the opioid epidemic that is sweeping the nation, so I thought I would try to come up with a project that could help in this area. This project will help in areas of patient safety, education, and the community. The setting will be implementing this type of program in an emergency room in a hospital. If success is seen there, then the plan is to expand to the inpatient setting as well. My contact person for this project is my boss, Lane. He has graciously accepted to be the mentor for this. He has 11 years of experience in the pharmacy industry. He is currently attempting to implement an Alto-based program in our facility, so he will have firsthand knowledge of what is required and the time and the tools needed to accomplish this. The need for this program is due to the ongoing opioid crisis. Colorado ranks 12th out of the 50 states in the self-reported use of non-medical use of opioids. 25% of Coloradans say they misuse pain medications. The amount of heroin seized in the state has drastically increased by 827% since 2011. Deaths attributed to opioid-related overdoses rose by 205%. Facilities should implement a program like this because there is an evident need to start somewhere to control the access to these drugs. Now you may say that the ED visit is only one visit, but when you have numerous patients who come in the door insisting on using certain drugs to control their pain, then the ED is contributing to the problem. EDs need to be part of the solution. With alternative treatment plans, the patients realize that there are other options, but they also realize that we, as a medical facility, aren't going to assist with them getting their fix. Numerous other alternatives to using just medications exist. There are a number of people who are involved in this type of program: doctors, pharmacists, and other community members who provide pain management services. The stakeholders in this project are going to be the patients, the physicians, and the facility who is implementing the program. The patients are an active stakeholder because they are the ones that this program is essentially setting out to help. This program wants to help patients become less dependent on the opioid drugs by suggesting other treatments available to them. The physicians will need to be highly involved to learn the best meds to use in place of the opioids. They will need to be actively aware of the resources available in the community, but also need to be on board to not prescribe or order opioids in the ED setting. We want to treat the pain, but not in a harmful way. The hospital where the ED is located is a benefactor here because they are trying to set a precedent for the way that healthcare is trying to go. More patient-centered care, but also safer care. There are also other departments in the facility that might benefit from this program as well. Outpatient therapy departments could see an increase in patient flow and revenue due to referrals being made from the ED. The communication factor is going to be different for each group. For the patients, there is going to have to be some education on the changes and what they need to expect when they come into the ED for pain interventions. There's going to be some potential for making them upset until they figure out that we are just trying to come up with different ways to help. We like seeing the patients, but we don't necessarily want to see them in the ED over and over and over again, seeking out drugs for whatever might ail them. The doctors in the facility probably won't require as much in the way of education, but more of coming from a patient safety approach. We want the patients to be treated, but we don't want to be responsible for adding to the current drug crisis. I want to address the aspect of taking care of the patient, and I want the doctors in the facility to be involved so that they are more willing to stand behind implementation and want to work together for the greater good. One of the goals of this implementation is to lower opioid use in the emergency department. The other goal to this program is to increase patient traffic in other areas of the facility. Some of the requirements for this implementation to be successful are, willing doctors to participate in using other drugs to treat pain and to be on board with not prescribing as many opioids for patients. A committee to implement the program and to follow the progress. A determination of who is responsible for knowing and updating the resources and community for the doctors to be able to refer to when suggesting alternative methods of treatments to patients. The committee will need to come up with a plan to measure success or a plan to improve the program once up and running. Administration support is needed to encourage the change and to make a point that this is in the best interest of the patients in the facility. This is a list of the literature that I reviewed to summarize in the next few slides. Why is this program needed? As, again, an overview, this program is needed because there is a current opioid crisis in America. The CDC has reported that nearly 500,000 Americans have died from an opioid-induced overdose between the year 2000 to 2014. Financial impact is just as equally mind-blowing. Insurance companies have spent approximately $78.5 billion a year on the non-medical use of opioid pain relief. There have been states that have made it possible for patients to sue providers for damages that may come about due to their addiction. Who was involved? The history behind this epidemic is that way back when, in about 1986, a pain expert, Russell Portnoy, did a small case study that showed that high doses of opioids were successful in treating pain and did not cause addiction. When the study was published, numerous pharmaceutical companies started marketing their drugs for more uses and at higher doses. Doctors also jumped aboard this thought process and started prescribing opioids based on the methodology of Mr. Portnoy and his research that using these drugs would not cause people to get addicted to them. Most of the people addicted to opioids were prescribed the meds from their primary doctors. Doctors need to have an increased awareness of what types of medicines they are prescribing. They need to know the different alternative treatments that are available in their area. The patients rely on these medications to keep active and to keep their quality of life. Unknowingly, most are addicted. This article I was reading made mention that most patients were addicted to opioids because they had been prescribed by a doctor for either short or long-term use. Come to find out from the increased number of people addicted to pain medications, it has been decided that maybe opioids is not the best way to treat or manage pain. There are numerous alternative treatments. A con to the alternatives is that insurance plans may or may not pay for them. A pro to the alternatives is that this is not addicting and less chance for the patients to turn to a higher, more powerful addictive drug. Lifestyle changes could lead to alleviate flare-ups of pain. With the implementation of this type of program, I am hoping to bring awareness of what some of those other alternatives can be. I want to promote an all-around better way of dealing with pain and take into account all aspects of patient care. This article brought to light that now that more pressure has been put on providers to make patient-centered care more prominent, we have to take into account their satisfaction and their opinions in their care and treatments. This article was based on the perspective of the patient, the actual opioid user. It takes a village to provide this quality of care because more often than not, your pharmacist is involved, knows you, knows your struggle. Your doctor is obviously very involved in your care, and there are therapists that might be involved. Your family members and your support circle are also very intertwined in your treatment options. The main point to this article was that there are numerous people involved in patient care when dealing with pain management and trying to keep people from using opioids to treat their pain. There has to be a respect factor for the patients. There also needs to be integrated relationships built on trust. Patients want to be in control of their health. They want to be involved in making the decisions to actively be a participant in their healthcare needs. In a push to make healthcare more patient-centered, there needs to be a trust between the patient and the provider. The provider should not be influenced to prescribe or suggest a drug based on what that drug rep or company could do for him or her. Prescribers are under pressure to provide high-quality care but also keep the patients happy, which in turn leads to the patient satisfaction surveys. If you upset the patient by not providing the type or service of care they are accustomed to having, then you score low on the surveys. This is ultimately linked to the amount that you get reimbursed from Medicare. It's going to take teamwork and all-around consistency to get beyond this crisis. Ethics plays a big role in coming up with solutions that benefit everyone involved. This article raised questions on what types of alternative treatments were out there to be utilized by providers to try and combat the overwhelming use of opioids to treat chronic pain. Some of the treatments listed could offer successful outcomes for those who are addicted to opioids to fight the chronic pain. Being a Christian facing this dilemma, Romans 15:13 says, I pray that God, the source of hope, will fill you completely with joy and peace because you trust in Him. Then you will overflow with confident hope through the power of the Holy Spirit. If I have hope and I am trusting God with my steps and following His plan for me, then that hope will be evident in all that I do. I want to be a light of hope for those who are seeking help in any and all areas of their lives. I want to remember to pray for understanding, patience, guidance, and ultimately compassion to show God's love and light through me. In conclusion, there are pros and cons to this type of program being implemented. I do believe that the pros outweigh the cons because patient safety is being ultimately addressed. The community is going to benefit from everyone being more self-aware and wanting to be involved in their care. The stakeholders involved in this should want to be a part of the implementing of this type of program. They will only benefit from trying to reduce the reliance on opioids. According to the National Survey on Drug Use and Health, people who are addicted to opioid medications are 40 times more likely to be addicted to heroin. If we can help to lower this statistic in any way, it will be worth the implementation process and the change required to make a difference. Thanks for watching. Here are my references that I used in my presentation.